Dear ladies and gentlemen, I would like to thank the scientific committee for choosing this abstract as an oral presentation. And this morning I will present you cumulative success rates following minimal ovarian stimulation and natural cycle IVF from a cohort of unselected infertile patients from a single center from Japan. As you all know, the first IVF cycle, successful IVF cycle, was performed in an unstimulated natural cycle, and since the inception of IVF, there's an increased interest in mild approaches to IVF. However, the clinical uptake of these mild approaches was quite slow, and only a few specialist centers, such as the one in Japan, which apply it on a very large scale, and there's a considerable debate about the real value of mild approaches. When I think about mild IVF, there's a number of questions which come to my mind, such as these, and with this retrospective study, I would like to try to answer some of them, the ones in green, and maybe give some suggestions to the other questions also. I was fortunate enough to, during 2011 and 12, to spend a one-year research assignment at the two branches of the Kato Ladies Clinic in Tokyo and Kobe. And this data comes from the Kobe branch, which handles more than 3,000 cycles per year, uniquely with minimal ovarian stimulation or natural cycle IVF. This cohort includes all consecutive patients during 3-year period, stimulated exclusively with natural cycle IVF or minimal ovarian stimulation with clomiphene. And I must emphasize that there's no patients treated with conventional IVF at this center, so it was impossible to make comparisons within the patient of this center. All patients received single embryo transfer, and there was an increased use of blastocyst culture, vitrification, and delayed frozen embryo transfer. Patients were not selected based on their age or basal FSH values. The two main protocols that were used in this center is a completely drug-free natural cycle IVF protocol, where the induction of final oocyte maturation was performed with a GnRH agonist, or extended clomiphene regime, where clomiphene tablets were administered until the day before triggering, and likewise the final oocyte maturation was induced by a GnRH agonist instead of HCG. So let's look at the baseline characteristic of this cohort. At starting treatment, there are 727 patients, and as you can see, most of them, more than half of them, are over 38 years of age. Most of them had primary infertility, no previous child, and poor responders and patients with high FSH values are overrepresented. Most of the patients, up to 60%, underwent conventional IVF treatment at other centers. So to answer the first question, what is the expected cumulative success rate? Broken down by age groups, you can see that this is a crude cumulative live births, so the actual number of live births reached. In younger age groups, rates are quite acceptable, and it's even not bad in the intermediate age group of 38 to 40. But in patients 41 years old or older, it's considerably lower, and actually the oldest patient who had a live birth in this cohort was 44. We have also calculated the expected live birth rate based on the assumption that what would happen if no patient would drop out and all patients would do up to 9 cycles. You can see that there's a considerable difference. Now, what is the dropout rate? You can see the blue line that the dropout rate varied between 13 to 25% per cycle, which is lower than the reported dropout rate in patients after conventional IVF, which can reach 40 to 60%. How many cycles are recommended? One can readily see that there's a plateau in all curves, and maximal success is reached after 4 to 6 cycles. In if converted in time from starting the treatment, then one can see that after half a year or a little bit more than 1 year, the maximal success is already reached. Now, to answer these questions, who would benefit the most from mild approaches in this cohort? We performed a multivariate logistic regression analysis, and this is presented as a poster at this meeting. And after including 9 variables, only 5 were found significant still. So you can see that success rate is declining rapidly after 38 years of age. And previous IVF was a negative factor, prognostic factor, whereas having a previous child was a positive factor, and compared to natural cycle IVF, clomiphene had better efficiency. The interesting question, of course, what everybody interested in, how these results can compare with a conventional IVF, and unfortunately I was unable to compare it with patients of the same cohort because there's no conventional IVF treatment in the center. But I superimposed the data of the Japanese cohort with the largest study from the US, from a SART registry, where you can see the dotted line represents cumulative success in over 500,000 cycles, and maximal success is reached after 3 to 4 conventional IVF cycles, whereas the full line is the Japanese cohort. And in each age group, you can see that the per cycle success rate is lower with the Japanese approach, but because the dropout rate seems to be lower, at the end, at least in this favorable age group, the same cumulative chance of success is reached, even in the intermediate age group. Whereas in patients 41 or older, the mild approach, this is the Japanese cohort, seems to be less efficient. And I'm coming to my conclusion. For me, it seems to be evident that the efficiency of mild approaches has to be measured on a cumulative basis. This Japanese approach, where GnRH agonist is used to triggering and only single embryo transfer is performed, undoubtedly has a better safety profile. Lower dropout rates suggest more patient friendliness, and at least 6 cycles are recommended with this approach. And this mild approach seemed to be efficient in patients younger than 38 years of age, might be of value also in patients of intermediate age, 38 to 40, but seems to be less beneficial in patients 41 or older. And finally, I would like to thank the whole team of Kobe Motomachi Yume Clinic and acknowledge the great support that they give me during my stay in Japan. Thank you very much for your attention.
Thank you very much, Dr. Bodri. The paper is open for questions. And may I ask you first, 7% of your patients, as I understand from the slides, were between 45 and 52 years of age. How realistic is to offer to this patient a single embryo transfer after minimal or no stimulation at all?
Yes, as I said, patients were not excluded based on their age, and because this clinic treats a considerable number of patients, this cohort was also significant. This was a retrospective analysis data, so one can see that there was no live birth in patients over 44.
So if you do it again, you wouldn't recommend that you would consider these options for patients above which age?
Well, as said, patients over 40 have less chance of success, but there was no formal comparison made. So characteristics of Japanese patients might be different from European ones, and it's difficult to set an age limit, especially if a patient wants to do treatment.
Okay. Also, I would like to comment on your conclusion. I think because of the fact that there was no comparison to a conventional stimulation method, suggesting that this approach is an efficient alternative is not exactly correct. It is efficient in the terms that it produces pregnancies, but whether it's efficient alternative, which implies a comparison, we don't really know that. And also we don't know much about the dropout rate, although it appears to be very promising. We don't know anything about it comparatively to conventional IVF. So I think we should be a little bit more conservative to this conclusion.
Sure, I totally agree, yes.
Any more questions?
Okay, thank you very much.